Hello, everyone. Thank you for attending today's Medicare webinar. We're referring to this as the Medicare Proper Medicare Billing and Coding Part 2. We appreciate you being part of today's call. As a reminder, please put your phones on mute, or if you're on your computer, make sure your speaker phone is on mute, so only the speaker can be heard and not any conversations in the background. Also, to know who is participating on today's webinar, please make sure you type in your first and your last name. We do see some first names only showing, so please type in your last name also. This webinar has been approved for 1 hour of mandated CE under Billing and Coding by the California Board of Chiropractic Examiners. Participating DCs that will be on the webinar today for 45 minutes or more will be emailed a CE certificate. Personal note for those of you who are on the February 27th Part 1 Medicare webinar, the PowerPoint slides and the requested letters along with the CE certificate are forthcoming, and they will be emailed to you. For today's presentation, it'll be by Dr. Tracy Cole, who's been involved with CCA for a number of years. He's been on the former Medicare committee as co-chair, also the former Medi-Cal committee. He is a member of the current Managed Care and Insurance Committee of CCA, and also he is a past president of CCA. To provide additional assistance today is Mr. David Martinez. He joined Dr. Cole on the February webinar. He is the co-chair of CCA's Managed Care and Insurance Committee, and also CEO of Accurate Medical Billing and Audit. Mr. Martinez was also the presenter at the December webinar on ERISA. If you have any questions, you can type them in, and they will be addressed during the last 10 to 15 minutes of the webinar. And also, we are also offering 2 hours of Medicare at the Sports and Wellness Symposium. It'll be down in Anaheim on that class will be on Saturday morning, April 21st. So please consider participating at the Sports and Wellness Symposium. It has been submitted for 18 CE hours, of which you could pick up 2 more hours on Medicare. So Tracy Cole will be presenting that. So think about that, and we'd love to see everybody there. I'm now going to turn the webinar over to Dr. Tracy Cole, and just as a reminder, Tracy, go ahead and say next, and we'll move on to the next slide when you're ready.
All right. Thank you, Mary. Yeah, just to kind of reiterate one point that Mary brought up, for those of you that were a part of the Part 1 seminar, we also talked about a form for documentation that we are trying to develop, and I am working on that together with Dr. Bob Johnson, who I see is on the call as well. And as soon as we get that formulated adequately, that will also go out. So for those of you that were part of that, yes, that will also be forthcoming. Make it so, as you see on this title slide, my email is at the bottom there. You might want to make a note of that, especially if your question doesn't get answered during this hour. Feel free to contact me by email, and I will try to get back to you as soon as possible. All right, next. Mary already mentioned most of this, but in addition, I am the CCA representative to the Noridian Contractor Advisory Committee for California. That's a panel of different provider groups in California that take their concerns to Noridian. I've been a part of that. I go to the Los Angeles meetings. Dr. Dean Harmon, who's done that for many years, continues to go to the San Francisco meetings and is also a great resource. I'm part of the ACA Medicare Committee and also a Northern California alternate delegate at the moment for the American Chiropractic Association, who has been a great resource for Medicare questions that I cannot answer. Next. David, you're on the call. Do you want to go ahead and introduce yourself?
Thank you. Yeah, my name is David Martinez. As what Mary stated before, I am the owner operator of Accurate Medical Billing and Audit. I've been in the industry. Started in 1988. I was a claims examiner. I'm a certified professional coder. I'm a certified professional coder instructor, a certified HIPAA professional. I'm a certified chiropractic professional biller. I'm also a certified healthcare claims auditor. I'm a certified medical reimbursement. So you can say that I'm pretty certifiable. So, but I'm here to lend a hand to Dr. Cole, and I'm just going to be in the background and jump in as needed. Unfortunately, my email address is not in there, but you can email Dr. Tracy, and if you have any questions for me, I'd be more than happy to answer those also. But thank you for the nice introduction. I will just take the back seat right now. Thank you.
All right, thank you, David. Okay, next. So, as we've already noted, a lot of what we'll be discussing in this webinar has to do with billing, coding, and we will touch on a few things that I did touch on lightly in the previous webinar, in particular, the Advanced Beneficiary Notice Form. But LCD, which stands for Local Coverage Determination, is the document that Noridian, in fact, all Medicare carriers have, that contains information on how to bill Medicare. And in that document, the ICD-10 code categories are listed. As you see, Group 1 includes all of the subluxation codes, and Group 2 are the different categories of ICD-10 that are considered secondary diagnoses that are grouped according to their severity. Now, when I present this, or when I have presented this live, sometimes people ask, how many treatments qualify as short, moderate, or long-term? Well, the answer is really up to you, and as I talked about in part 1, whether you are showing functional improvement or not. Because if you treat someone for a set amount and they have not changed, then chances are you either, and they plateau, you either need to release them or move them to maintenance care if nothing has changed. So I can't really give you an answer on how many visits each of those entails. Would you agree with that, David?
Yes, that would be inaccurate. Yes, I would agree with that. Yes. Okay.
Yeah, just so you know, because the question quite often comes up, how many visits am I allowed on each of those categories? Well, the answer is there is none. You have to be able to show functional improvement. So hopefully that answers that question. All right, next. All right, for submitting claims to Noridian in our area, be aware that although we are not mandated to treat or see Medicare patients, if you do treat them or see them, you are mandated to send a bill to Medicare. Of course, we know the CMT codes, and that if you do progress or proceed, to maintenance therapy after treatment is done, the ABN form indicates that, or if option 1 is chosen by the patient, then you would have to send a bill, and we will cover that a little bit later in this hour when we get to the ABN form. Anyway, you're not allowed to opt out of Medicare. If you see a Medicare patient, you must enroll, and that also causes some confusion that we'll try to clarify in the next couple of slides. If you treat a Medicare patient, you have 12 months from that date of service to bill, or they will deny it. You cannot balance bill a patient if you do not meet that deadline. And of course, we know what the codes are that they will accept. Next slide. Okay, so since this is a point of confusion, I decided to include chapter and verse from the Medicare Benefit Policy Manual of why when you see a Medicare patient, you have to bill Medicare. So in Chapter 15, Section 40, agreements with Medicare beneficiaries are not authorized or as described in these sections and purport to waive the claims filing or charge limitation requirements or any other Medicare requirements. These have no legal force and effect. So for example, an agreement between a physician or practitioner or other supplier and a beneficiary to exclude services from Medicare coverage or to excuse mandatory assignment requirements applicable to certain practitioners is ineffective. The carriers, Noridian in this case, will refer such cases to the Office of Inspector General. Of course, this does not apply to non-covered charges. It only applies to the chiropractic manipulative therapy codes. So bottom line, again, if you see a Medicare patient, you have to bill to Medicare. Next slide. And in Chapter 15, Section 40.4, the definition of a physician or practitioner is, the definition of physician anyway is limited to doctors of medicine, osteopathy, dental surgery, podiatric medicine, optometry. Those are the physicians by definition that can opt out. The next paragraph says the opt-out law does not define physician to include chiropractors. Therefore, they cannot opt out of Medicare and provide services under private contract. This question comes up, and David, I'm sure, would agree, this question comes up over and over and over again. If you see a Medicare patient, you can't opt out, therefore you have to bill Medicare legally. And again, we're just talking about chiropractic manipulative therapy, 9894041 and 42, the services that are covered by Medicare. You cannot opt out, you cannot avoid sending a bill to Medicare, but as we'll get into in a minute, unless it's maintenance care and unless an ABN form has been signed and option 2 has been checked. But like I say, we'll talk about that in a minute. All right, next slide. So PAR versus non-PAR providers really kind of demands some investigation and talking about the differences of those two categories. So when you enroll in Medicare, you have the choice of being a PAR or non-PAR provider. As a PAR provider with Medicare, you agree to bill Medicare and accept assignment of benefits directly from Medicare. As a non-participating provider or non-PAR, you can choose to accept assignment or not. From what I've been told, most people choose not to. If you do not accept assignment, you are allowed to collect directly from the patient up to the allowed limiting charge. But a bill must still be sent to Medicare. The patient is reimbursed at 8% of that amount by Medicare. You cannot go past that limiting charge. The limiting charge amount depends on where you practice, as well as whether or not you have successfully reported on PQRS, as well as whether you have attested that you have a certified EHR system. Now, when the notes from Part 1 go out, there should be an attachment that goes with it that includes the fee schedule for your area. So if you're non-PAR and you want to know your limiting charge, you have to look up where you practice and see what that limiting charge might be. Now, if you do not know whether you successfully reported PQRS or whether you have a certified EHR system, you can look that up at the website that the federal government has on you that lists whether you are successfully attested or whether you reported PQRS adequately. And that website is qpp.cms.gov. Again, that's qpp.cms.gov. I did not get that into the slides, but that's where you can look up your status. Because people often ask, how do they know what their living in charge should be? And that's something you have to research and see what your office status would be. All right, next slide. So the primary diagnosis codes in Medicare, of course, 98940, 41, and 42 are the primary subluxation codes, and or the manipulation codes. The ICD-10 codes, are the 5 areas: the cervical, 99.01, thoracic, 0.02, lumbar, 0.03, sacral, 0.04, and pelvic, 0.05. Those are your primary diagnostic codes. Next slide. So, as far as what should go on the claim, the summary of what should go on the claim should include the following: the date of service, of course, the place of service, your procedure codes, your initial date for that course of treatment, your subluxations, which are the primary first diagnosis, your secondary diagnoses, which are the symptoms or conditions, and of course, your chiropractic NPI number. Any failure to report those could result in a claim denial. Next slide. So just a few highlights. In item or box number 21 is where your diagnostic code should go. No decimals should go there. You need to code to the highest level of specificity if that's applicable, and you have room for up to 12 of those. Each region that you treat, each subluxation region that you treat, requires both diagnoses. You can't just bill like a subluxation code only, or that will be denied. You need to list clinically significant codes that apply to the condition, and document. If you have several or run out of room, make sure everything is documented in your records if you run out of room for diagnostic codes on the claim form. Next slide, sorry. The box 24E, of course, is where the diagnostic pointers go. 24J is your individual practitioner NPI number. 33A, your group or solo NPI, depending on how you enrolled with Medicare. Next slide. So let's do a Medicare modifier review. And after this, there will be a little bit of a quiz to see what you know or what you've learned about these modifiers. To begin with, we are probably all familiar with the AT modifier, which is used on active treatment. And that is used, of course, on covered services, which for Medicare, again, is the spinal CMT only. As you see, it's meant to represent to Medicare that the care you administered was medically necessary under their Medicare guidelines. Obviously, it would never be used on maintenance care. So make sure, if you haven't already looked it up, that you understand the definitions of acute, chronic, and maintenance care as per Medicare guidelines. Next slide. The GA modifier. This modifier indicates that there is an ABN form on file, again, which is used only on covered services, spinal CMT codes. The ABN form, as we know, is the form that you use when a covered service is expected to be denied due to lack of medical necessity. If the treatment of a Medicare beneficiary is maintenance care, therefore would be considered not medically necessary and not reimbursable by Medicare, you would have the patient sign the ABN and you would append the code, the CMT code, with that GA modifier. Next slide. The GZ modifier is when there is an ABN form not signed or not on file, again used only on spinal CMT covered service codes. You would use this when an ABN should have been signed, but it wasn't. It's a modifier that is a measure of good faith towards Medicare that you recognize you made an error or you just didn't get the patient to sign it. But in that case, if that happens, you cannot collect payment from the patient. Next slide. GY modifier. These are this modifier for non-covered services, which are services that are excluded or do not meet the definition of any Medicare benefit. So that's all non-covered services, which is anything that's not spinal CMT. So that's, of course, any modalities, any E&M codes, x-rays, and all of those things. This is a modifier you would use. It's required on all services other than manual manipulation of the spine. And note that you do not use this GY modifier on maintenance care spinal CMT. Next slide. GP modifier. This is a fairly new addition that we'll talk about some more after this slide, but it's services delivered under an outpatient physical therapy plan of care used on the therapy service only. So it's a modifier required on most therapy codes and would be used in addition to the GY modifier, like 97035 or 97124 GPGY. Still does not mean that those therapy services are reimbursable by Medicare, that is, if they're delivered by a doctor of chiropractic. Next slide. So this is taken from the ACA, and it defines where this GP code and some of the others came from. An MLN article or a Medicare Learning Network article was fairly recently released last year on 12/21, where CMS announced that always therapy services billed must have the appropriate therapy modifier appended. And CMS has a list of the CP codes that are considered always therapy and therefore require a GP modifier, such as 97140, 97012, and so on. And that GP modifier must accompany that service regardless of the provider type. And the ACA clarified that GP does include chiropractors. You see the definitions below there. GN would be speech therapists, GOs, occupational therapists. So for us, again, this just applies to modalities. The GP code, if you are billing that to Medicare for the denial, presumably, would need to be added. Next slide. So let's test your knowledge a little bit and see if you know the answers to these next 4 questions. So you have treated a patient with maintenance care spinal CMT. Is it reimbursable under Medicare? Now, I seriously considered having the Jeopardy thing going right now, but I refrained. So it's a simple yes or no. And go ahead and hit the next key. And that is, of course, no. You've treated a patient with maintenance care spinal CMT. It is not reimbursable under Medicare. That's different than you send the bill, but it would, since it's maintenance care, they will deny it. Therefore, it is not reimbursable. All right, so next slide. Number 2, you have treated a patient for maintenance care spinal CMT, and you know it isn't reimbursable under Medicare. You also have a properly executed ABN on file. So which modifier do you append to the code? A minute. And go ahead and hit next. That would be the GA code. So you do have the properly executed ABN on file, patient signed, and so in that case, it would be the GA modifier. All right, next slide. You have treated a patient for properly documented chronic care, hence active, spinal CMT. Which modifier do you append to the code, and is it reimbursable? A, ATN yes, B, GAN yes, or C, GYN no. A minute. All right, hit next. That would be A, ATN yes. It is active care as long as the patient continues to show functional improvement. It would still be considered active. It's when they plateau that it's no longer considered active. So the AT modifier would be used, and of course it's reimbursable. All right, next slide. You are billing Medicare for therapy services, which you know are statutorily excluded for doctors of chiropractic. Which modifiers do you pin to the code? A, GP, B, GY, or C, GP, GY? And go ahead and hit next. I probably gave it away, but yes, C, GP, and GY both for the modalities that are not reimbursed or not covered, I should say, by Medicare. You would append those modality modifiers with GP and GY. All right. I wanted to thank the ACA for that question, for these questions. I thought that was helpful to understand some of what the modifiers entail and to have a quiz about it at the end. All right, so next slide. All right, maintenance therapy. I think we understand, hopefully, that treatment is considered maintenance when chiropractic treatment is supportive and it's no longer corrective, when further clinical improvement cannot be expected from continuous care. Hopefully, you're using outcome assessment forms and rechecking those every month or so when you do your re-exams, whenever that is. And when things are changing after a bit, you know that you are no longer administering corrective care and it's supportive, and then it becomes maintenance. So it's not a Medicare covered service, but you must bill if option number 1 is checked on the ABN form by the patient. We'll talk about the ABN form again in just a minute. So maintenance services, as defined by Medicare, include services that seek to prevent disease, promote health, prolong, enhance quality of life, and maintain or prevent deterioration of a chronic condition. Next slide. So here's the ABN form. This is the most current edition as of June 17th of last year. And it shows on there what the dated form up in the corner 3 of 2020. You can find that at that link or just Google it, but that is the most current form. Although the only thing they changed on it was a disclaimer on the bottom or towards the bottom about non-discrimination. Next slide. So what is it? It's an ABN is written notice that provider gives to the Medicare beneficiary prior to that service or procedure rendered. So as I talked about earlier with that GZ modifier, if you forget to do it, you cannot go back and have them sign it and consider the service reimbursable after it's been administered. So anyway, the ABN sign when you believe Medicare will not pay for some or all of the service, again, the CMT, and it indicates when it's properly done that the beneficiary is financially responsible. Next slide. So here are the 3 option choices that the patient, not the doctor, not the staff, but the patient would check. Option 1 is that the patient wants the service listed above, which again would only be spinal CMT care. And of course, as it says, you can be asked to be paid now, but you still, on that option, would have to send a bill to Medicare, which they will, of course, deny. Now, if the patient checks option 2, that's when you don't have to bill Medicare. You can ask to be paid up front, and the patient cannot appeal if Medicare is not billed. So that is the only instance where you would, the only instance where you would not bill Medicare with this. Option 3, they don't want any of it. I don't want the CMT care listed above. They're not responsible for payment and cannot appeal. So again, the beneficiary must make the decision. Provider cannot select those choices. All right, next slide. So with the ABN on an extended course of treatment, extended course of maintenance treatment, A single ABN can be signed up to 1 year if the services are identified, the duration of period of treatment, whether it's once a month for a year or whatever it may be, and that there are no changes to that scheduled maintenance treatment. However, if there's a new incident, a new episode, if you remember part 1, I talked about episodic care, the patient falls down, injures themselves, something's changed, then the ABN is null, you start over with active treatment, and once they're plateaued and back to where they need to be and you want to go back to maintenance treatment, then a new ABN form would need to be signed. Hold on, my computer just decided to go to sleep on me. Anything you want to add, David, to that?
No, I think not at this time. I think later on in the presentation, we'll talk about the mandatory billings. We'll go over that again. But yeah, you're right on track on that.
My computer woke back up, so we're good. Go ahead and do next slide. The ABN is not required for services that are excluded, which is anything not CMT related, so therapies, ultrasound, x-rays, E&M codes, nutritional supplements. They do not ABN form for those. I always hate, because this slide comes directly from Noridian, that last bullet point that says they can voluntarily sign the ABN form. I don't recommend that because it just confuses the patient, but I couldn't get that last bullet point to delete. So my advice is just to limit the ABN form usage to maintenance therapy for CMT care, chiropractic manipulative therapy. All right, next slide. So questions often comes up about the ICD-10 list. And I talked about it earlier, that if you're looking for the list of included ICD-10 codes from Medicare, Noridian, you can navigate to that website. You're looking for the local coverage determination document, and you should be able to find it there at the Noridian website under California, northern or southern, whichever area you live in, but it's all the same. So, all right, next slide. And this is where you will find the Noridian Medicare portal homepage, or that I should say, that is actually what it looks like. And this is a great page to go to, and I touched on this in part 1. If you've not enrolled on the Noridian Medicare portal homepage, you really need to do that, because that is where you can get beneficiary eligibility, things like whether simple questions answered, like deductible issues and claim status. If you need to do a reopening, if you forgot to include the AT modifier on a claim, for example, which of course will get it denied, you can go there and they should be able to do that. Be aware that as of early February, the operators at Noridian are no longer answering simple questions. They will refer you to this Noridian Medicare portal homepage. So be aware that you need to be on that if you're not already, and that will answer most of your questions. All right, next slide. I think that is it. Yep, did you want to add anything else before we go into questions, David?
No, but I guess I could want to add something. I want to reiterate, because the biggest problem I see, on my clients and when I do lectures, is that there's a lot of cash practice, or a lot of softwares that are selling cash practice, and not really understanding that even if you have a cash practice, if you have a Medicare patient that comes in, as Dr. Tracy said, you have to bill Medicare. I cannot reiterate that enough. That is one of the most misunderstood issues that are going on. That they, oh, I'm cash, so I could see the patient in cash. If the patient, and what Medicare says is you have to have a reasonable, a layperson's reasonable suspicion that they're on Medicare. Obviously, you take you do an intake form, you know they're over 65. So you have to ask them, hey, I see that you're over 65. Are you on Medicare? Of course, if they say no, then you're scot-free. But if they say yes, then you must bill Medicare. I want to stress that enough, that you have to bill. If you don't bill Medicare, you can be subject to a very substantial fine. The last thing I've seen that the fine now is up to $10,000. If you see a Medicare patient and you don't bill Medicare, you could be subject to a $10,000 fine. So again, I don't want to beat this into the ground, but I want to make it abundantly clear that it's mandatory that you do bill. Thank you.
All right, thanks, David. And one more quick thing that I can add related to billing is that, and I suspect David sees this a lot too, but we've seen several cases where providers bill exclusively a 98942, which of course is the 5 spinal areas, and they don't vary from that. And I can't stress enough to that point that if that's what you do, unfortunately, you kind of target yourself for audits. Somewhere down the road, it will become an issue. So, as I talked about in part 1, when you document, you need to thoroughly document to justify the number of areas that you're treating. If you have a patient that has cause for treating several areas like a 98942, then document it. But if you do that with every single patient because you say, you know, I do that with everyone, therefore that's what I'm going to bill, but your documents don't back that up, that's where the problems occur. You have to be very explicit, very detailed in your documents to justify the code you're using. And unfortunately, at least when I've been a part of looking at some of those, the documents just don't back it up. So be careful when you bill, and make sure that you document thoroughly and bill according to what you're treating and what you're documenting.
Yeah,
all right, we'll go ahead and proceed with the
Dr. Cole,
question.
let me add something to that real quick. So
Yeah.
if you bill a 98942, which Dr. Tracy said, Dr. Cole said, that's 5 areas of the spine. We all know that. On your CMS 1500, when you send that to Medicare electronically, you have to have 10 diagnoses to support that. You have to have the subluxation and the supporting diagnosis. So what's going on is there are a lot of audits going on because there was only 2 or 3 diagnoses. 2 or 3 diagnoses does not support the need for adjusting 5 areas of the spine. So I just wanted to kind of put that in there too.
Very good. All right, so Mary or Kaylee, do you want to read the questions? I mean, I actually see the first one here already. So how do you want to do that?
If you see the first one and you want to answer it, go ahead. I'd probably just suggest that you repeat the question.
Well, the first one I see at least says that well, I might have scrolled down on it a little. Here we go. Okay, there it is. Dr. Helen Zaremski, sorry if I massacred that. Not registered with an HMO, for example, ASH, so the HMO is denied since I'm not a provider. Do I still send a bill to Medicare to get the denial, even though HMO does not cover me and they would be cash? In that instance, you're talking about a Medicare Advantage plan, otherwise known as Medicare Part C. If you are not a contracted enrolled provider with that plan, then you do not send a bill and they are a cash patient. You would charge whatever your usual customary fee is. That is the only instance there that would apply. So no, you do not send a bill to Medicare. You can charge them cash.
Okay, let's go back up to a couple other earlier questions. One from Dr. Lewis. Is there any action at the national level to allow chiropractors to opt out of Medicare?
Yes, I can speak to that. The ACA is working diligently on Medicare and Medicare expansion. They are, at this point, progressing towards trying to get a bill introduced to expand Medicare. They are very aware of what you're asking, of the desire to opt out, and their response, since they're the ones working on it, is that they would really like to expand Medicare first, separately, before they embrace or work on the opt-out provision. And so they're aware of it. There's been a big push to do it. But right now, with the push to expand Medicare, they feel like it would be a bit disingenuous to also say, we'd also like the ability to opt out. Although, it will eventually definitely be looked at.
Thank you, Tracy. There's also, whoops, I see more questions are coming in. There's also one.
Go ahead, read them. I'm not keeping up either.
No, it's okay. There's also one from Dr. Kobe. On the claim form, can the pointer, people keep, okay, hang on.
Well, David can also answer some of these claim issue questions.
Yeah, can the pointer go to all diagnoses or only the first one? Does that make sense?
The pointer should be pointing. The pointer should be pointing to the services that are applicable for that line item. So if you have a 98940, it should obviously have the applicable diagnosis pointing to that procedure.
Thank you, David. One from Dr. Hall. We've noticed that Medicare is not forwarding the PT codes onto secondary insurance companies. Is this because the proper modifier may not have been used? ABN is
Correct.
on file. So if the patient gets the 98940 and ultrasound and transaction, then does the PT need GPGY?
Correct.
Correct. Okay, hope that answers it, Dr. Kelly, Dr. Hall.
If you don't apply the correct modifier, even to the modality code Medicare or Noridian, I should say, we'll just ignore it, and it won't get forwarded to the proper secondary.
Okay. Here's another question. Say you're billing thoracic pain and thoracic subluxation. Does it matter which code goes first?
Yes, it does. The subluxation code always is first, always is primary. The secondary code, whether it's pain in thoracic spine or whatever is applicable to that patient and what they're presenting you with, that always goes second.
Okay, thank you. Here's another one. There are several diagnosis codes Medicare does not accept, such as extremity. So we can only do, okay, this is where I don't know. It's Dr. Hans Delfo. I guess I don't know the codes well enough. The C's, T's, L's, thoracic lumbar, cervical, thoracic lumbar, and pain code. Are there any other diagnosis codes that we can put in?
Other than spinal, no, it's the 5 spinal areas: cervical, thoracic, lumbar, pelvic, and sacral. Extremities are not a covered area for Medicare purposes, that is. Mm-hmm. Therefore, if you treat an extremity, it would be separate. It would be, it'd be cash if that's what you're billing is in this case. It's not a covered Medicare service.
Okay, thank you. Here's another one. Nope, hang on. If you have a diagnosis code of M99.01 or 0.02, would a secondary diagnosis of M5413 cervicothoracic, don't know how to say that word,
Radiculopathy?
Yeah, radiculopathy instead of
Noridian?
one diagnosis for each level. That's from Dr. Johnson. That's his question.
Okay. Yeah, it really and I don't have the local coverage determination document pulled up. That's where you'll have that question answered. If that code is not on that LCD document where you find the ICD-10 code list, they won't cover it. So to answer your question, you need to look on that document and see if it's there.
Okay. Regarding an auto accident and the patient does not want her Medicare billed, are we still required to bill Medicare in this instance?
If it's a auto accident, yeah, auto accident, PI would be billed first.
Okay.
Are you required to Medicare afterwards? No, not. David, do you want to confirm on that?
Correct, yeah. Since any services like a PI would be primary to Medicare, you would bill primary to Medicare. If necessary and want to, if they have a limited liability or something like that, you can bill Medicare, but you don't have to bill Medicare. Obviously, if they have coverage primary, such as PI, that's one of the rare exceptions.
Here's one from Dr. O'Toole. I have billed 98942 for the majority of my patients because they have problems in all areas. I have only billed the supporting diagnosis on the first code. I haven't had an issue. So basically, is that okay?
I'm surprised.
Yeah. Technically, right now, Medicare is, they don't want to admit it, but they're 3 years behind. So they may not catch you today or tomorrow, but I'm not saying they're going to, but that is on their radar. That's one of the easiest ones to look for, is they're doing what's called a desk audit, and they're looking at the procedures that are billed versus the supporting diagnosis that are billed. If it's not a match, then they are putting that on the top burner when they get around to doing those audits.
Yeah. So in this instance, just to amplify a little bit of what David's saying, 98942, if you have the documentation to back up all those areas you're treating and can justify it thoroughly, that's one thing. But the fact is, you have to, as I talked about earlier in the webinar, you have to have a secondary diagnosis to go along with every primary subluxation code that you're using. So, that would be another area that would need to be fixed. The best answer to keep away from the auditor's radar is to make sure that your CMT codes that you bill are varied. Some 98940s, 41s, 42s that, are dependent on the patient that presents in front of you. That is what will, get you the most ability to sleep at night, quite frankly. But you just got to do it based on what the patient's showing you, presenting you with.
Thank you. Here's a question from Dr. Jackson. Can I charge a patient and not bill Medicare for treatment that is outside of the spine, such as a knee subluxation?
A knee? Is that what you said?
Knee. Knee.
Yeah, knee. Well, any extremity is not a covered Medicare service. Knee, wrist, ankle, any of that. Jaw. All of those are outside the spinal area and therefore are not covered, and therefore you can bill the patient. You do not send a bill to Medicare. You can have the patient pay cash.
Okay, and here's a couple of questions from Dr. English. If option number 1 on the ABN is signed and it's going to be denied, why do we have to bill?
Yeah, well, you're talking about how the ABN is written. I don't particularly understand it either, but it is what it is. If they decide to check it, you have to bill Medicare, and yeah, we know it's going to be denied, but that's just the process you have to go through if they check box 1. Yeah, I don't like it either, but You just have to sit and hope that your patients check box 2. You just can't check it for them.
Okay. Also, will Medicare pass along CPGY codes if CMT care is maintenance?
Well, if Medicare, the GPGY code is used on therapeutic modalities like massage or ultrasound or whatever. If you're doing maintenance care, yes, that would be denied. That would be, if you're asking would it be passed along to the secondary. What would you say, David?
The question is GPGY codes. So again, you're right. Those are physical therapy modalities. I would make sure, obviously, there's going to be a big issue where Medicare not passing along. You always have to follow up. You can't really rely on Medicare passing it through. Honestly, in my practice, my company, we only see about 50% of the claims going through to the pass through. So, we just automatically attach the EOB and send it to secondary anyway. So, that's one thing you have to keep look for. Medicare is not going to be a foolproof forwarded to the secondary. You just have to make sure that you do your due diligence on that.
Yeah, that's an excellent point. Whoever does your billing needs to be prepared to copy the Medicare explanation of benefits and send that along to the Medicare secondary if Medicare doesn't automatically forward it along.
Okay. Dr. Johnson has a follow-up to his prior question. The M54.13 is on the list. My question is that it says you need one secondary diagnosis for each spinal level. So since M5413 is on the list and it spans 2 spinal areas, is that sufficient instead of the cervical, however you say that word, radiculopathy and thoracic radiculopathy?
I'm going to try to imagine what he's referring to, but let's say, for example, that you're documenting in your notes a subluxation, say at C7, and another subluxation at T1, then that secondary diagnosis would make sense. You'd have a primary of cervical subluxation, the secondary of that code, another primary of thoracic subluxation, and the secondary of that code. All I can say, in my opinion, and David can disagree or agree, is yeah, you could probably use that same secondary code, but I've never tried that with Medicare. What would you think, David?
Those are effectively known as cheat codes. You can get away with it. It happens all the time. If the diagnosis covers 2 areas of the spine overlapping, yes, you can use that, and it is acceptable.
Yeah, that was my assumption. So I would say yes, you can do that. To answer as well, I would agree that you can do that.
Okay, does anybody else have any other questions out there? I think I've pretty much picked up everyone's questions. So I'll wait just a little bit here to see if anybody else wants to type in another question.
Well, again, you also have my email, tcoledc@gmail.com. So just in case you think of something later, I can also forward things to David as well.
Okay, well, I'm not seeing anything more, so I want to thank Dr. Cole and Mr. David Martinez for their presenting today for the Medicare billing and coding, and we will make available these PowerPoint slides as well as send you the CE certificate. I think I see something here, Mr. Qatar. Oh, somebody else has a question?
I'm still here.
Okay. Anyway, we do appreciate it. Thank you, everyone, for participating, and I hope you got some valuable information today on the Medicare webinar. Again, these are free for CCA members, so we encourage you non-members to consider joining, because it's webinars like this that are an added benefit to your membership. So keep that in mind. Thank you so much.
All right, thanks, everyone.
Appreciate it. And we'll see you next time.
Thank you.